you. If you listened to our show last week, we did a little preview, or I guess a hint of what we're talking about. Well, forget hint, we just said it. We're talking about ketamine today. A somewhat controversial methodology uh, for treating certain things, PTSD, chronic pain, treatment resistant bipolar depression, if I'm correct, and some other things. And why it's controversial is because, for the most part, ketamine, at least for most of society, is known really as a recreational party drug. So Doctor, how did this thing where people take and go to parties and raves and have fun turn into a therapeutic of sorts?
Well, you see, you have to look at the history of ketamine, and ketamine has been around for a long time. I mean, basically, we're talking 1960s
Wow.
when it was initially developed as a anesthetic, right? And it was initially developed as an anesthetic for veterinary medicine for animals. Eventually, grew up into being an anesthetic uh, for for humans too. Now, there were some issues with ketamine at anesthetic doses causing some problems like severe nightmares, right?
Hmm.
In essence, ketamine is an anesthetic that is very interesting because it doesn't have a lot of the respiratory depression you see with other anesthetics that basically cover the whole brain. In that you don't have to have somebody breathing for you when you go under anesthesia. So it's a very versatile anesthetic, even though it has some complications. But in essence, it is a dissociative drug, meaning it's kind of in the brain reacting like psychedelic. So you get dissociative experiences. I mean, dissociative experiences means like out of body experience. You don't feel that you're in control. You feel that you are disconnected from yourself. So, for a long time, it was known as Special K among the drug abusing population as a substance that you can get dissociated with, right? So, and because of the safety of it, it became popular for people to steal ketamine and to sell it in the black market as a drug of abuse. Now, we have known for a very long time that it was a very useful anesthetic, especially in war, in the military, because you can actually use it in the field with somebody who was injured, right?
Isn't really that's how it kind of came about to the attention of the medical community through the military, giving microdoses to get guys from the battlefield to the hospitals using, I believe it was a nasal injector, and then they were doing psychiatric and psychological um, interviews at the end and realized, wow, there's something going on here beyond just the anesthetic part. Is that correct?
Yeah, I mean, there are a number of studies that were done in the military. One that was really fascinating had to do with looking retroactively on the people who had received anesthetics, and separating the groups that received ketamine versus a group that received other anesthetics, either for battle injuries or getting into the mesh units for surgery and things like that. And what they found, they found something very interesting, and it was that those who received ketamine had a significantly lower rate of PTSD than the ones who receive other anesthetics. So that is kind of the first initial findings we had in psychiatry. Eventually, we started to notice that people who had depression and received ketamine had a significant improvement of their mood after the ketamine injection. So people decided, and actually the National Institute of Mental Health started really looking closely at the effects of ketamine in the brain from the basic science perspective, from the clinical perspective, to see if patients will get better. And it was really fascinating to see what happened. I mean, I've been using ketamine for my patients probably for about 7 or 8 years as a medical director of a ketamine clinic. And it's really interesting how versatile this substance is and how well accepted it is by patients. I would say probably significantly underdosed. I mean, underutilized, not underdosed, but
Gotcha.
underutilized.
And it's not an opiate of any sort. There's no addictive potentiality there.
There are some people that had concerns because the mechanism of action uh, of ketamine does have some intervention into the opioid system. But even those who have abused the drug, we don't seem to see the traditional withdrawal from that. But the whole neurochemistry of the brain is complicated. So substances go to different pathways, and even though it has a dissociated pathway uh, in terms of the effects on glutamate, for example, and it may have some opioid pathways too. But we don't see the respiratory depression we see with either traditional opiates or some of the traditional anesthetics.
So it would be essentially impossible to overdose with, or at least very
Uh,
difficult.
well,
And if someone were to overdose, what would that look like? Now, with certain things, their breathing stops, their heart stops. What would an overdose of
well,
ketamine?
the problem is that in an overdose, of course, we have concerns about the primary effect in the brain, but we also have concerns of the primary effect in the rest of the body. So, at very high doses, you may have problems with elevated blood pressure, palpitations, arrhythmias. So, could you die from an overdose of ketamine? Yes. Is it likely that you're going to die from a microdose used for depression? No. But um, I've been doing medicine and psychiatry long enough to tell you that impossible is not a word we normally use.
Gotcha. So it obviously take a lot as an overdose, and you just mentioned microdosing. That's the way it's being used clinically. What type of percentages and milligrams or whatever is what are we looking at here compared to, for example, somebody using it at a rave or a party?
Well, I think that a rave or a party, people don't care much about dosing, right? I mean, it's not like they sit down and say, well, let's try zero point 0.4 milligrams per kilogram for this rave. No, people take it and wait to see what kind of effects they have. So people will have different reactions to different doses. In the clinical setting, it can be used in two different ways. It can be used intranasally or it can be used intravenously. Now, most of the time we use it intravenously. It's probably easier to regulate and more controllable. I think that there's a tendency to utilizing more of the intranasal route of administration in the patients with chronic pain.
Hmm.
But that requires that you actually take the ketamine to a compounding pharmacy where they're going to create a mist that you can utilize intranasally. That I've rarely done that, but it can be done, right? Intravenously, I in my practice normally start at zero point 0.4 milligrams per kilogram and try to max out at around 1 milligram per kilogram. Those are under anesthetic doses. So when you use those doses, some people may have dissociation, some people may not. Some people may have a quasi reaction of dissociation, for example, right? Like feeling a little disconnected, a little excessively relaxed. That for some people, especially people who tend to be very anxious and obsessive, is kind of problematic because they feel that they're not in control, right? But in general, most people tolerate the medication quite well. Usually, when you do an injection, you're going to be monitored on your blood pressure, monitor your heart, you're going to use a specialized pump to use the infusion. Usually lasts about 40 minutes. Uh, but what I find really helpful is the response to it, right? Because what we're seeing, in particular with people who have failed antidepressants, they seem to respond well. Now, that doesn't mean that if you use it first line, it's not going to work. But there's a tendency in psychiatry to leave the non FDA approved treatments for depression as a second line and not a first line, right? Uh, but there's one exception, though. We find that in patients that have acute suicidal behavior, you want to get them out of the depression very quickly, right? You want them to decrease the impulsivity and depression and negative thinking that leads them to think that they'll be better off dead. And that is one particular area that, regardless of what extent of depression you've had, or what responses you had with with antidepressants, that we should be using ketamine, right?
Mm.
That is one area that I think is very, very important. The other area, excuse me, are those patients who have been traumatized, either rape victims, motor vehicle accident victims, shooting victims. I always recommend to the emergency room physicians, and this is a medication that frequently paramedics carry with them, right? Like to tranquilize somebody who's very agitated or somebody who's been traumatized. Or if you have a rape victim and they're going to have an examination in the emergency room, I always advise the emergency room to start utilizing ketamine. And that is because of what we talked about before, the PTSD issue, right? That if you use the ketamine early enough, you may prevent that recurring memory process that is happening in the brain that results in nightmares and flashbacks and recollection of the trauma.
So ketamine can be used for acute issues, like somebody having an immediate trauma, just like in the battlefield or rape. But then you mentioned PTSD. I've heard this chronic pain, and then the treatment resistant depression. Are there any other things that are ketamine is used to treat? And by
So,
treat, we have to always remind our audience this is not cure. This is to help manage the symptoms.
it's really fascinating because some people don't like to use the word treatment because treatment usually implies that the patient is going to get cured. The reality is that these are interventions. There are interventions that lead to decreased intensity of symptoms and in some cases elimination of symptoms. But again, in the behavioral arena, we always talk about reduction of symptoms and learning new behaviors, right? So what we found with ketamine is that there are other behaviors that are starting to be explored. For example, alcoholism.
Mm.
For example, some anxiety disorders, drug abuse. We're starting to see that, for example, patients who have an issue with substance abuse, alcoholism, or depression together, and you treat them with ketamine, the impulsivity on the use of the substances decreases, right? And we still don't know exactly how, because there's a lot of mystery in the brain is still to be uncovered. But the reality is that the brain is like a black box, right? You have this problem, you do this treatment here in the black box, and you have an outcome. It's very difficult to measure everything that happens in the brain because we don't know the brain 100%. But we do know that if we do this here in the black box, you have better outcomes. And at the end of the day, is the outcome that we're looking for, right? It's not just the control of symptoms. Now, in the emergency situation, I think in particular with trauma patients, there is a twofold improvement. One is the prevention of developing PTSD by utilizing ketamine, right? And the other side is the treatment of PTSD that already occurred, meaning the patient that had trauma and became uh, developed significant PTSD, and now it is requiring some treatment for that.
So you mentioned that it is not FDA approved. What does that mean for people who want to potentially use this, or even for physicians who are interested in putting this as part of their practice? What are the impediments, or what does that really mean to the rest of us?
Okay, when you have a medication that says FDA approved, and for somebody like me who's been doing this for so long, FDA approval means that they're being placebo-controlled over trial. I mean, double placebo-controlled double-blind studies where patients have been assessed against placebo, meaning people with depression, one group on placebo, one group on ketamine, and see what responses you get. The FDA usually requires that your response on the substance being investigated is better than placebo, meaning statistically better.
Mhm.
Now, and that has to be duplicated, right? So what you have, like for example, Prozac has proven to be better than placebo in improving symptoms of depression. Okay, and is statistically significant. Same with anxiety, same with OCD. Now, because ketamine has been around for a very long time. There's very little incentive for pharmaceutical companies to study it
Mm,
because it's off patent, meaning anybody can do it, right? So the financial incentive is not there, but the scientific incentive is there, and the response is there. Now we're seeing now, for example, one company that is splitted the molecule of ketamine into the left side and the right side of the molecule, and decided to utilize uh, one half of the molecule, okay, to treat depression. And it's a substance called Spravato. Spravato is a natural spray that has to be administered in the clinic, right? The problem is that Spravato is terribly expensive and
mm,
it's very difficult for insurance companies to approve. So we continue utilizing ketamine. And off label means that it hasn't been studied, okay, and the FDA has not going to look at it, okay, as a full molecule. It is very unlikely that that's going to happen. Now, but one of the beauties of ketamine is that it's opened up a whole new world of research into how it works in the brain. And they're actually looking for substances that look like ketamine that may be of some help. So there's a whole area of non FDA approved treatments, okay, that we utilize all the time, right? So, for example, if you have um, generalized anxiety disorder and you want to use TMS, you can use it, but it's not FDA approved, right? If I use an antipsychotic approved for adults and decide to use it as a child, right, it's not FDA approved. So FDA approval doesn't mean that I can't practice medicine. It just means that I have more of an obligation to explain to people, okay, that this is what we know about the substance, this is the research that is available, these are the risks and the benefits, and the patient has to give informed consent based on the fact that it's not FDA approved, right? And we have a lot of treatments like that. I mean, as substances come into the market, we start discovering that they have other uses, right? Like right now, there's a big movement on some newer medications for diabetes that seem to produce significant weight loss. So the
mm,
research is now going into the weight loss, but they're still not FDA approved for that, right? So some biological newer medications. So we have to understand that when we say not FDA approved, it means that the FDA has not approved it. It doesn't mean that I cannot prescribe it, but I have an obligation to explain people in a higher degree.
and it also doesn't mean it has not been studied. It just has not been specifically studied or approved by the FDA. But I assume then it means it's also not covered by insurance.
That is correct, and you're absolutely right. When you don't have FDA approval, it means that the physician has to follow the science and the standard of care, and that has to be supported by something, right? So, like National Institute of Mental Health has looked very closely at ketamine. They're very excited about it, but without the FDA approval, you cannot market the medication for that specific indication.
Mm,
It
okay.
doesn't mean you cannot use it, but you cannot proactively promote it.
So you've done the research. You provide this. A person comes into your office with significant depression. Would not be the first thing you would prescribe, though. Correct?
That is right. Now it depends. Like if you come to me and you're 20 years old and you come to me because your parents kept you from hanging yourself, right? And you continue to be terribly despondent, irritated. You still feel that life isn't worth living. I have a number of options. One of the options, but you need to be hospitalized, right? We need to get you more stable. But anything that I prescribe, even if I hospitalize the patient, is going to take 2 to 4 weeks to work, right? So if I'm in the hospital and the patient is already started an antidepressant, continues to be severely suicidal, I may suggest that that patient gets ketamine, right? Maybe the patient has not had a full treatment, has not failed a number of antidepressants in the past, but there I'm specifically looking at decreasing the intensity of the suicidal thinking by reducing impulsivity and getting the patient out of the depression a little faster. Now, that may require the patient continues with antidepressants. It's not unusual because I do 4 or 5 calls a week on patients wanting to get ketamine. I don't just give ketamine to anybody who wants to get ketamine, right?
Mm,
But
okay.
if I do a consult, I would say, okay, you have a history of depression. You try an antidepressant, didn't work, or you couldn't tolerate it. You continue to be depressed. You might be a good candidate for ketamine, right? These are the pros, the cons, and then the patient may agree or not agree. But it's important to understand that it's not something that people should be going to get just because I feel sad, I want to try ketamine, right? There's a lot more clinical assessment that needs to happen. I mean, not unusually in our ketamine clinic, we would get someone referred by their psychiatrist. I mean, I'm not going to question the psychiatrist's referral. We may give that patient ketamine or a psychologist or a therapist, but we collect some degree of history so we know what we're dealing with, right? In the clinic that we have both psychiatry and anesthesiology, so we work together.
So who would not be a candidate for ketamine?
I try to avoid ketamine on any patient that suffers from psychosis,
Mm.
meaning if you are hallucinating or if you're having severe paranoia or you feel that you're being persecuted or that the voices from aliens are telling you to kill yourself, I would probably not utilize ketamine in that particular patient for a number of reasons. It may worsen the psychosis, or if the patient gets dissociated, it may actually worsen the problem, right?
So what are patients' responses to it? You say it works well, but what's the process like? What do they experience? What do you hear about as a physician? Do they come back and say, "Hey, that was the best time of my life," or "Oh my God, that was kind of crazy"? We know the results seem to be good, but just give us a typical response to somebody that you've put on ketamine.
Well, most of the patients that I've treated with ketamine, I would say a third of them uh, get the infusion. They report feeling a little strange when they get in the substance. And we usually start at zero point 0.4, zero point 0.5 milligrams per kilogram, which is a fairly low dose. So we're trying to avoid significant dissociation. About 70% of those who don't have mild dissociation, after the second infusion, they report feeling less depressed. And that starts giving you a signal, and normally we do 4 to 6 infusions in a 3 week period. Now, there is another third of the patients who have a little more dissociation even at lower doses. Now, what I have found, and I think this has been reported before, there don't seem to be any relationship between the degree of dissociation and response. Those are
Hmm.
two separate things. Um, the the dissociation, getting disconnected, having an out of body experience. When you get those patients, most of them would tolerate that well, but I had one patient, for example, that actually I was there with him during the infusion, which I'm normally not there, and he started developing panic attacks
Wow.
during the infusion. And it wasn't a traditional panic attack, but it was a panic reaction to feeling out of control. So what we have learned is that you're very obsessive, very intellectual, very tight in terms of how you manage things. Being out of control might be not a very positive experience. So people feel weird and they feel agitated, they feel very anxious. So we have to recognize that. Um, and then there's another third of patients, I would say about 30% of patients who may have a dissociative experience or not, but after a couple of infusions, 2 or 3 infusions, you don't see a lot of response. So my experience with ketamine is that we see a response in about 70% of patients, right? So we have to tell patients that in advance. Interestingly enough, 70% response is usually what you see with medications. Now, let's define response. What does response mean? For us in the scientific community, response means 50% reduction of the symptoms you had before the infusion or before the treatment with medications. Now, there's something we call remission, meaning elimination of symptoms, meaning very low symptoms in comparison to the normal population or non-depressed population. And the remission rates are about 30 to 35%, which is about the same with medications. The difference with ketamine is that it's very fast.
Hmm.
So it's a very quick response. You don't have to wait very long. Most people do fairly well after the infusion. Some people may need monthly or every 6 week boosters of the medication. Some people goes months without any problem. So it's not. There's no way for us to predict that yet. So I have patients that been going and getting ketamine infusions once a month for years, and they
And
seem to do.
is there any data or anything on long term use whatsoever?
There's not a lot of data in humans uh, in terms of long term use. The only study that I've seen was a study done in monkeys, and it was done a while ago, and it was using very, very high doses of ketamine daily
Hmm.
for a long period of time. And they did notice that some of those monkeys had some cognitive difficulties. But you're talking about super therapeutic, very high doses for a long period of time, which is very unlikely that humans are going to be exposed to that amount of ketamine.
So what's the future for ketamine? Well, how do you see where it's going? Obviously, you're involved with it. You have you're part of a treatment center.
Well, ketamine is kind of like a key for research that is opening a lot of doors, right? So we have to think of it as the beginning of a new era in psychiatry.
Hmm.
And there are other substances that are still not legal in the United States called psychedelics. There are also dissociative substances that seem to be very promising. So, why do I call it a key? Because it's starting to open up our knowledge of how the brain works, but more than that, how the brain repairs itself, right?
Hmm.
So we starting to see substances like psilocybin, which is magic mushrooms, ayahuasca, LSD that was available also in the 60s, that is starting to create a lot of um, curiosity among researchers in terms not only about the substance itself, but about how does it work in the brain. And what we're finding out is that there seems to be not only neuromodulation, improvement of the connections to the brain, but also brain repair. And that is
Hmm.
really fascinating in terms of how brain connections get improved by the use of these substances. So we're still in the early stages of learning how this works, but it's extremely promising. Why is that? Because the theories on the medications we use today for antidepressants, which is serotonin, norepinephrine, dopamine, ACTH, you know, those that theory was created in the 1950s.
Wow.
Since the 1950s, we have not come out with a lot of new answers for depression and anxiety of a new mechanism of action, right? So we kind of refried the beans for 70 years, right? Newer substances, as effective but less side effects, more effective on anxiety, and so on. But the reality is that when we get down to mechanism of action, we're like 70 years behind.
Wow.
So ketamine, psilocybin, ayahuasca, LSD are keys are opening a new vision of the brain. And actually, we just started a new research project on a new substance. It's a new mechanism of action for depression. We just got awarded a contract to do research on this, which is A very interesting mechanism of action that has nothing to do with serotonin, norepinephrine, dopamine. I can't talk very much about it because we're in the process of recruiting for that research. But we're starting to see the opening up, right, of people saying, wait a minute, can we move away just from dopamine, serotonin, norepinephrine, and ACTH, and then start looking at deeper levels of the brain, and then start to look at this systematically in the context of this being a systemic illness and not just an illness of the brain?
So this really is a kind of on the precipice of something very, very new, and it sounds like if there's actually or repairing occurring in the brain, we could actually, for the first time, be inching toward real treatment and potential cures instead of just managing symptoms. Is that correct?
That is absolutely correct. I mean, we need to move away from uh, reducing symptoms to improving functioning so we can balance the brain. Now, what we've also learned that depression, anxiety, bipolar disorder, schizophrenia are much more complicated illnesses than just brain function. And they also have a lot to do with the interaction with our environment, okay, and our psychological development. So we cannot negate the importance of the psychological and social issues on rehabilitating people. So let's get into rehabilitating the brain internally and then rehabilitate the patients behaviorally to psychological and social means.
And are those things combined? I think you mentioned to me once about people doing ketamine with active therapy at the same time.
Yeah, we're starting to explore two types of therapy. One is talk therapy while you're doing the ketamine. The other one is music therapy. And I'm very much in favor of music therapy because I think that music is the oldest form of therapy in the world, right?
Well, to that point, I know someone who's experienced a lot with ketamine. We've had him on our show, Kyle Kingsbury, and he is told me that the music has a substantial effect on him depending on what he listens to while he's going through those sessions. And so that's kind of interesting. And I know this is a topic we can go on forever. We are out of time today. Maybe next week we could either continue it or start talking about psilocybin or some of the other things out there. Ayahuasca, DMT. I know Kyle is involved with that. Maybe even get him back on the show. Once
Yeah.
again, Doctor, appreciate your time. Of course, everybody share, like, and subscribe, and leave your messages or your questions in the comments area as well, and we'll get to them the next show if we can. Have a good one. Take care.
Thank you, Vince. We'll see you next week. Thank you, everybody.